Now we start the industrial symposium for Prof. I'd like to thank Prof's company for their effort and their contribution to this successful meeting.
Please take your seats. We are short of time and we want to start this symposium. I have the pleasure and honor to introduce Professor Campstol. He's going to talk about the use of combined mTORs and calcineurins in renal transplant patient, in de novo renal transplant patient. Professor Campstol.
Okay, so thank you very much again. Thank you very much for the introduction, and thank you very much for all of you to be here. I know it's a little bit late, and probably all of you are a little bit hungry, so it's time for lunch. So thank you very much to be here, and thank you very much also the people for Novartis to give me the opportunity to come back to Cairo and to come back to Egypt again. As the chairperson introduced, I will try to talk in the next 25 minutes, no longer than 25 minutes. What I consider the best way to use mTOR inhibitors. I think this morning I mentioned several times mTOR inhibitors. I think mTOR inhibitors are a very, very useful drug in organ transplantation, in kidney, in lung, in heart, in liver, but unfortunately I think in the past we don't use the drug in a proper way. I think that today, after a long time, 10, 12, 15 years, I think we'll learn really how to use mTOR inhibitors, and I think, and I am absolutely convinced about that, I think that with the proper use of mTOR inhibitors, we can really improve the quality of life and we can improve graft and patient survival to our patients. So I'd like to discuss in the next 25 minutes with you what I consider the best way to use mTOR inhibitors. Let me just try to start with the pathway of mTOR. You know very well these pathways. And just to remember that mTOR pathway, PI3K, AKT, mTOR, is a very important pathway for all our cells. It's a pathway that will control protein production, protein synthesis. And when you control protein production, you control cell growth, you control cell division, and you control angiogenesis. And it's not only specific for lymphocytes, T and B, it's also in all our cells. So when we use an mTOR, we need to have the idea that we are using a drug that will block really the protein synthesis and the protein production in all our cells. That could be very beneficial, but also we need to know that in sometimes dose dependent could be negative in sometimes. That's something that we need to learn and we need to know. As you know, these pathways will be controlled by different growth factors. Important growth factors like vascular endothelial growth factor, like insulin-like growth factor, by oncoproteins, by nutrients, and also by interleukin-2. Interleukin-2, as you know, is the main cytokines on lymphocytes proliferation and differentiation. So remember that mTOR, it's not only specific on lymphocytes, T and B. All our cells express these pathways, and all our cells could have the consequence of an mTOR inhibitor like everolimus. So when we use an mTOR inhibitor like everolimus, we stop cell division, we stop cell growth, and we stop angiogenesis. And that could be very important and very beneficial, probably not only for the graft, not only in organ transplantation, also for other important parts of our body, like cardiovascular disease, like cancer, like infections. And that's something that I like to transmit and I like to know and to share with you, that probably mTOR, it's not only a good immunosuppressive drug for the graft, I think it's a good drug for our patients. So it's absolutely well known that the use of mTOR has an immunosuppressive effect. It prevents the incidence of acute rejection, But as I mentioned, there are other interesting points that could be attributed to the use of mTOR. mTOR is an anti-proliferative drug, so the use of mTOR could be associated with the prevention of graft fibrosis. And also, it's absolutely clear the use of mTOR inhibits vascular remodeling, so could be positive to prevent cardiovascular events. And it's very clear that the use of mTOR prevents left ventricular hypertrophy, which is very common in our patients and could be very negative in long-term follow-up. Also, as you know, the use of mTOR has an anti-cancer effect, and all the studies show lower incidence of cancer in transplant patients using mTOR. And also something that we learned in the last 5 years, the use of mTOR has an antiviral effect. For different mechanisms, immunological and non-immunological, it's absolutely clear today, and I think there is evidence that the early use of mTOR could be associated with lower CMV, lower decay. And finally, the use of mTOR as a potent immunosuppressive drug could be really associated with CNI minimization and then lower CNI toxicity. And finally, something recently that we learned in the recent years, the use of mTOR has a role on the acquisition of immunotolerance. Many studies show that when we use an mTOR, the number and the percentage of Tregs is much higher than when we don't use of mTOR. So with all together, I think that we can consider that mTOR could be a very positive drug to prevent immunological damage, to prevent graft fibrosis, but also a quite positive drug for the patients in the terms of cardiovascular disease, in the terms of cancer, and also in the terms of infection. And as we know, and we discussed this morning, I think we have a problem in long-term follow-up, and the problem is named chronic allograft damage, and the problem is named anticipated death related with cardiovascular and related with cancer. So if we have a more soft drug, a drug which is better in the terms of cardiovascular scenario, in the terms of cancer, and also in the terms of infection, I think that this drug could be positive for our patients. But there is one key point, how we use the drug. And as we discussed a little bit this morning, we used the drug in the past in a bad way. We consider that mTOR inhibitors are like a miraculous drug, and all our patients in the chronic point with different problems could be solved just converting, late conversion from CNI to an mTOR. So in general, in the last 15 years, I think we mainly consider mTOR a rescue drug. When we have a problem, could be CNI toxicity, could be chronic allograft damage, could be cancer, could be severe cardiovascular profile, then we consider to stop CNI and to move from CNI to an mTOR. And we learn and we know that late it's too late, and we know that unfortunately we don't have any miraculous drug. So I think that we need to change our mind, and instead of using the drug on late conversion as a rescue drug, we need to change our mind and use the drug early after transplantation. And I think that's the key point. The immunosuppressive drugs are not used for rescue drugs, are used to be used from the beginning, from day zero, in a proper way, in low doses, to obtain the benefit. The benefit in terms of immunological points, but also in other points like cardiovascular, cancer, and infection. So I think there is one very important point that we need to change a little bit our mind, and instead of using mTOR as a chronic rescue drug, we need to move and we need to use the drug in a preemptive way as early as possible after transplantation. And then there are different options that I like to discuss with you. But I think first we need to change our mind, and instead of using the drug as a rescue drug, we need to move early after transplantation in a preemptive way, maybe with elimination, maybe with minimization. So on this way, I think there are 3 points and 3 ways to use mTOR inhibitors after transplantation. The first point would be with CNI minimization. The second point will be with free CNI therapy. And the third point would be early CNI minimization with MMF plus mTOR. First message, I think that this strategy today could be eliminated. It's a difficult strategy. We know and we learn that it is associated with a high incidence of adverse event. We know that we need to use in high doses. So in general, today, 2014, I don't recommend to use this strategy in your patients. I think it could be used in very specific group of patients, but the free CNI strategy, I think it's not the good way to use the drug. So we have two options to use mTOR from the beginning. The first option will be with early CNI minimization, and the second option will be with CNI minimization. Let me start with this strategy, early CNI minimization, and then I'd like to give you my feeling and what we do in our unit. Early CNI minimization. Start what we name conventional therapy, CNI, cyclosporine, tacrolimus, MMF, steroids, plus or less induction. And then after 3 to 6 months, if everything is going fine, with or without a protocol biopsy, eliminate CNI and introduce mTOR inhibitors. And then leave your patients with MMF, mTOR plus steroids. That's early CNI elimination, early CNI introduction of mTOR inhibitors. I want to mention that this strategy is not new. 25 years ago, Australian researchers, Gallagher and also Chapman, defined this strategy using azathioprine. And I think it's important that 25 years later, we review how are the results. And they developed these trials on early conversion from CNI to azathioprine. 3 acts, azathioprine from the beginning, early conversion from cyclosporine to azathioprine, and long-term cyclosporine. And I think it's remarkable that 20 years later, the best graft survival is in patients early converted from cyclosporine to azathioprine. So I think it's important really to learn and to take advantage from our trials, as we mentioned this morning, and especially these trials that 20 years later show that patients' early CNI and early conversion to a non-nephrotoxic drug is the best strategy to improve graft survival. And I think it's remarkable that 20 years later, graft survival is approximately 20% different in patients early converted from CNI to azathioprine. 6 months after transplantation, they stop cyclosporine and they introduce azathioprine. I think that today we have better drugs than azathioprine, so probably we can improve this curve, we can improve long-term graft and patient survival. I want to share with you 2 studies on early conversion. One with sirolimus, the other one with everolimus. Let me just go to the sirolimus trial, and I want to just to present this trial because we have long-term follow-up. That's the concept trial, French study, Roche sponsor, started initially cyclosporine, MMF, steroids with induction with monoclonal, and then approximately 3 months after transplantation, patients were random into groups. One CNI elimination, CNI withdrawal, with introduction of sirolimus, the other group CNI continuation. And also the authors do something that I consider not correct. They stop also steroids within the first year. I think to do 2 changes within the first year, it's too much change on the immunosuppressive therapy. But let me just try to work and like to share with you the results of this concept study with more than 200 patients. Very important, just graft survival and renal function. And I think it's remarkable that 4 years after transplantation, renal function, GFR, serum creatinine was completely different in patients early converted to an mTOR versus the group on CNI. And as you can see here, the GFR in patients on mTOR plus MMF is very stable. The GFR in the patients on CNI is progressively decreased. So I think it's important to remark that not 1 year, 2 years, at 4 and at 5 years, the tolerance of the strategy is good, GFR is better, graft survival is better, good safety profile with low proteinuria, lower CMV, lower cancer, and also very important, better renal function. So I think it's clear, and it's not only 1 year, which looks completely different, it's at 4 years follow-up. The other study that I want to share with you is the Zeus study. You know the Zeus study, that's a German study with approximately 300 patients. It's a study sponsored by Novartis and exactly the same design. Start of therapy conventional with induction, MPS, cyclosporine steroids, and from the 4th to the 5th month, random to the two groups. One arm CNI continuation, the other arm CNI elimination with the introduction of everolimus. And I think there are 3 or 4 important messages from this study. The first important and the first message and quite clear data, lower incidence of rejection. So this strategy in general is associated with a lower incidence of rejection, and as you can see here, no difference between the two groups. The second important point, the severity of rejection was quite similar between the two groups, so this strategy doesn't have a negative role on the immunological point on the development of rejection. The second important message, significant better GFR. Exactly like the concept study, during all follow-up, GFR was significantly better in patients early converted to mTOR, to everolimus, than the patients on CNI. So it's clear, and we know very well that when we stop CNI, there is a significant improvement in GFR, and we can see here that was maintained for 1 year or 2 years, and in the concept study after 4 or 5 years. And third important message, in general, the tolerance of this early conversion is quite good, it's quite acceptable. No big difference on the safety profile between the two groups. But it's important to remark that this strategy must be selective. And you know, because it was published by the group of Dr. Clemens Budel, that maybe they pay a price in the terms of DSA. And I think it's important, it's remarkable, and that's a problem, and that's a mistake, that there is a higher incidence of DSA in patients early converted from CNI to mTOR. But I think that the problem is a selection of patients. And I think when you really do this strategy in patients with low immunological risk, with a negative DSA, the follow-up is quite good. And data from the concept study, from the French study, at 5 years, the incidence of DSA was very similar and was lower in the group early converted to mTOR versus the group on CNI. So I think that the problem of DSA in the Zeus study was a selection problem. I think they convert patients with high immunological risk, they convert patients without steroids, and then maybe they pay a price. So I think that this strategy could be good, although we must be careful, and maybe we need to select our patients with mild or low immunological risk. If we do this early conversion in patients with high, then maybe we pay a price which could be quite negative. Again, from the concept study, no difference in the incidence of antibodies between the two groups. Group converted to mTOR versus the group on CNI. So just to summarize this strategy, I think it's a good way to use the drug. Although I think we need to select our patients, and maybe we need to use in patients with mild or low immunological risk. But I think using this strategy, probably we take the best of the immunosuppressive drugs. A strong therapy from the beginning, we prevent acute rejection with the use of CNA, and then in long term, we use a non-nephrotoxic drug, and the drug which could be good for the graft and for the patient. In general, this strategy was associated with a low incidence of acute rejection, good preservation of renal function, and very important, as you know, good safety profile, no difference on proteinuria, and two very important points when we use mTOR. Lower incidence of viral infection, CMV, PK, good cardiovascular, good cancer profile and good cancer benefit. So I think it's important that when we use mTOR, we always has the benefit in the terms of cardiovascular diseases and also in the terms of cancer. So in summary, this strategy I think could be good, although we must select the patients, and maybe we can use in patients with low or mild immunological risk. But I think that today, after 15 years using mTOR, we learned that maybe from the beginning and probably from the first year or 2 years, the best way to use mTOR will be with CNI minimization. And don't forget that the two mTORs, everolimus and sirolimus, were both developed with this strategy from the beginning, day zero, with low CNI, low tacrolimus, low cyclosporine. There are a large number of trials, of studies showing the beneficial effects of this strategy. And I think there are a lot of literature, a lot of trial, a lot of protocols with this strategy. This strategy has a strength and weakness, something that we need to learn and we need to know. First, let me start with the strengths of this strategy. And very important and first important message. This combination is synergistic on the prevention of acute rejection. Using this strategy, we block the production of interleukin-2 using cyclosporine or tacrolimus, and with mTOR, we block the effect of interleukin-2. So important, this strategy is potent and specific, it's high efficacy to prevent acute rejection, and all the studies show very low incidence of acute rejection. So remember, that's probably the strongest immunosuppressive therapy or the most potent immunosuppressive therapy that we have in our hands, with a good synergistic effect through interleukin-2 to prevent all immunological damage, all immunological activation through T and B lymphocytes. So low incidence of immunological damage. And again, the use of mTOR from the beginning is always associated with low viral infection and low incidence of cancer. And the third important effect of this strategy gives us the opportunity in some patients to individualize immunosuppressive therapy. And maybe in some patients we can consider after 6, 12 or 18 months the withdrawal of steroids, or maybe in patients with low immunological risk in long term, maybe we can consider to withdrawal CNI. Don't forget about the negative role of steroids on the cardiovascular area. So this strategy, potent and specific, gives the opportunity to individualize immunosuppressive therapy in the terms of CNI or in the terms of steroids. But we need to know that this strategy has also some weaknesses. Weaknesses mainly in the terms of safety profile. In 2 points, both dose and blood levels dependent. And that's something that we need to know and we need to manage. First, nephrotoxicity. Second, on the development of diabetes mellitus. This morning there was a comment about that, and that's something that we know now and we need to consider. But both are dose and blood level dependent. And with the synergicity of these two drugs, we don't need to use in high doses. Using in low doses the two drugs, we avoid these problems, and we have a very strong and specific immunosuppressive therapy to prevent most of the immunological damage. Let me just try to go on 2 studies to try to convince you about the benefits of this strategy. First study is the B156 from Novartis using everolimus in this CNI minimization plus everolimus. Just 2 arms, one with a standard cyclosporine plus MMF, the second arm low cyclosporine plus everolimus. And I think it's remarkable in the terms of efficacy and in the terms of rejection, much better than the control arm. Just focus on rejection, 70%, which is our actual incidence, 7% with this low cyclosporine, low everolimus. But very important, with this low incidence of rejection and low CNI, better GFR. Creatinine clearance was around 60 mL per minute with low cyclosporine, 53 mL per minute with a standard cyclosporine. Don't forget that the nephrotoxic drug is cyclosporine, it's not everolimus. So if we can't really minimize cyclosporine or tacrolimus without immunological damage, we have a benefit in the terms of GFR and also other points like cardiovascular and cancer. So the strategy looks quite good to prevent immunological damage and also to preserve renal function. But very important, low cyclosporine. We cannot use high doses. We need to use low doses of cyclosporine or tacrolimus, much lower as we commonly use with MMF. The second study that I want to share with you is a very important study. It's a 2309. It's a phase 3 study developed mainly in America for the approval of everolimus by FDA. 3 arms, 2 with everolimus. Forget this arm with higher doses of everolimus and just consider this arm with everolimus. Levels of everolimus from 3 to 8 nanograms per ml, doses with 1.5 milligrams per day, and low and reduced cyclosporine plus steroids, versus the control arm with standard cyclosporine, LPA, steroids plus induction. The first important message, low and reduced cyclosporine. If we want to combine with everolimus, we can use in a significant reduced way, approximately 50 to 60% lower doses, lower blood levels of cyclosporine. And with this strategy, we don't have any problems in the terms of active rejection, and we have a significant benefit in the terms of GFR. But very important, use cyclosporine or tacrolimus in a much lower doses, in a much lower blood levels. When we consider acute rejection, exactly the same without any higher incidence of acute rejection in the group with reduced cyclosporine plus everolimus. So that's quite important that this strategy is not associated with a negative point in the terms of immunological damage. And very important, beneficial effects in the terms of GFR, in the terms of renal function. Within the first 2 years, GFR, creatinine clearance, creatinine is better in the group with reduced cyclosporine versus the group of standard cyclosporine. Again, the nephrotoxic drug, it's not everolimus, it's not MMF. The nephrotoxic drugs are CNI. So if we can significantly reduce without an immunological risk, I think that could be very beneficial in the terms of graft and also in the terms of patients. And very important, when we use mTOR, when we use everolimus in low doses, the tolerance is much better. No significant difference on different adverse events comparing standard cyclosporine versus low everolimus, low cyclosporine. No higher incidence of any of the common adverse events, no stomatitis, no proteinuria, no different points. And very important thing, lower incidence of CMV infection. I think there is a global agreement that when we use mTOR from the beginning, the incidence of CMV, the incidence of BK is much lower than in standard patients. And I think now, in many cases, we can avoid prophylaxis when we use mTOR from the beginning. So, in summary, I think that this strategy is very potent and specific to prevent acute rejection, to prevent immunological damage. Both humoral and cellular rejection are completely prevented with this strategy. Very important message, when we use from the beginning, initial therapy must be based on CNI, tacrolimus or cyclosporine. Don't use higher doses or loading doses of everolimus from the beginning. Loading doses must be avoided. Start with higher doses of cyclosporine or tacrolimus and then progressively decrease and then progressively increase the dose of everolimus or CNI. On the long term, when we combine with tacrolimus plus everolimus, the total level of the two drugs must be around 10, 3 to 5, 3 to 6, 4 to 6 of the two drugs. The CU must be around 10 nanograms per ml. And like always, we can individualize immunosuppressive therapy. We can consider to avoid or to eliminate steroids after 6 to 12 months, which would be very beneficial for the patients and for the graft. and very important, like always, lower incidence of cancer, lower incidence of cardiovascular profile. So in general, there is a good tolerance of this strategy with a lower incidence of rejection with a good beneficial effect for the patient. But very important, as I mentioned, we need to use the drug in low doses. Everolimus, when we combine with cyclosporin, 0.75 milligrams BID. When we combine with tacrolimus, 1.5 milligrams BID. Very important, cyclosporin, 125, 150, and then progressively decrease, and as a maintained doses must be from 50 to 75 nanograms per ml. With tacrolimus, initial levels 6 to 8, continuing doses levels from 4 to 6 nanograms per ml. And the levels of everolimus always, I think, must be from 3 to 8 or 3 to 6 nanograms per ml as the target doses. And this way, I think that the incidence of nephrotoxicity or the problems of diabetes are much, much lower. Let me just finish. I have 3 slides. Let me just finish. So, very important thing. And then I think we need to put in the table which drug is better, mTOR or MPA. And I think if we put all together, I summarize for you, I think clear, I will finish this. mTOR are significant, better immunosuppressive drugs than MPA. Let me just try to review for you advantage and disadvantage. When we consider mTOR more potent and specific immunosuppressive drugs than MPA, we could be used mTOR as a base therapy, and we have the beneficial effects in the terms of cancer, antiviral, and antifibrotic effects. It's true that the safety profile of mTOR are a little bit difficult, and it's true that we need to monitor the drug. But when we put together both drugs, with MPA, maybe we can prevent a little bit more the incidence of acute rejection, but absolutely clear, mTOR are stronger immunosuppressive drugs than MPA, and that gives the opportunity to significantly minimize CNI without any immunological risk. So, in summary, I think that mTOR are better immunosuppressive drugs than MPA, stronger, more effective, pleiotropic, and give the opportunity to individualize immunosuppressive therapy. In this way, as you know, people from Novartis are developing a very large trial with approximately 2,000 patients. The name is Transform Study, which I am absolutely sure will change the follow-up and the conventional therapy, comparing CNI minimization plus everolimus versus what we today name a standard therapy. 1 year, 3 years, 5 years. And I am absolutely sure that this study really will be positive, showing that the reduced CNI plus everolimus will be a better immunosuppressive drug than what we name a standard care of today. Let me just finish with a conclusion, saying that long-term results of renal transplantation did not significantly improve in the last decade. Chronic allograft nephropathy and death are the main responsibles of that. I think that nowadays CNI could be necessary initial after transplantation, but maybe detrimental in long-term follow-up. mTOR inhibitors could be a useful immunosuppressive drugs in organ transplantation for both to prevent acute rejection and also through their anti-proliferative, antiviral, and anti-cancer effect. And finally, early preemptive conversion or de novo use of mTOR plus low CNI may help to prevent the development of CAN and could preserve renal function in long-term follow-up. That's all. Shukran, and thank you very much for listening.
Thank you, Professor. Or Dr.
Thank you very much. Thank you very much. Thank you very much.
We have, yes, for discussion. Yes, I do.
Professor Campstol. Thank you very much for the nice talk. If there is any head-to-head trial comparing steroids and everolimus, and superiority of one over another? This is the first question. The second question, in applying the early conversion policy, we should perform a protocol biopsy prior to conversion. What if we found a minimal degree of rejection, borderline, etc., in the presence of normal serum creatinine? Should we proceed for minimization or elimination in spite of this degree of rejection? Thank you.
Thank you very much for your comments and questions. Going to the first question, I think we never will see a prospective trial comparing sirolimus versus everolimus. I think that in general, the two drugs are very similar. The two drugs have the same mechanism of action. The two drugs have the same safety profile. So I think the only difference is on pharmacokinetic. One is every 12 hours, the other one is every day. I think the two drugs are very similar, and you can decide which drug you prefer. You prefer to work with the rapamycin or you prefer with the ferritin. I want to tell you that we in the past worked a lot with the rapamycin, and these days we work a lot with everolimus, and we feel very comfortable using and working with everolimus. About the second question, if you want to do an early conversion and you do a protocol biopsy at 3 months and you find a subclinical acute rejection, I think you cannot convert at that time the patients. And what I probably and consider the patients, if there is a subclinical acute rejection, it doesn't mean that probably the immunosuppressive therapy that the patient is receiving is low. We are under immunosuppression. So what I recommend is maybe to treat with steroids, and then maybe repeat the biopsy 3 months later and consider a conversion. Or the other thing, treat with very low pulse steroids and convert from MPA to mTOR inhibitors. Remember, CNI plus mTOR are a stronger immunosuppressive therapy than CNI plus MPA. If you have a subclinical rejection, you need to increase immunosuppressive therapy. So there are two options. One, treat with steroids, do another biopsy and consider. The other thing, treat with low pulse steroids and convert from MPA to an mTOR. And I am sure that the follow-up will be better. And then, depending how is the follow-up, you can take the best decision. But it's not the good time to do a conversion from CNI to an mTOR.
Thank you very much, Dr. Joseph. The organizing committee is pushing us to finish the. It seems that مفيش أكل بعد كده.
Thank you very much.
Thank you very much.